Zirpe. I would now like to invite our next speaker for the day, Dr. Soniya Bhagat, who is the head of quality assurance for Ruby Hall Clinic Hospitals Group, Pune. Welcome, Dr. Soniya.
Okay. So my topic for today is medication management quality indicators. As we are all working in the organization in the hospital setup, we give some sort of interventions to the patients, and it is the patient and the family who expect a good quality output from the interventions what we provide. I unquote the saying of Mr. Phil Crosby, quality is free, it is not a gift, but it is free. The unquality things are what cost money. Monitoring quality indicators plays a major role in healthcare setup. Since we are celebrating World Patient Safety Day with the theme Medication Safety this year, we will be today discussing about the quality indicators for safe management of medications in the organization. Quality indicator by definition, they are the standardized evidence-based measures of healthcare quality that can be used with readily available hospital inpatient administrative data to measure and track clinical performance and outcomes. They are the foundation for quality improvement in healthcare. They are the commonly used improvement tools which are identified to monitor structure, processes, and outcomes. Most of the medication errors in the organization resulting in patient harm occur in medication prescription, medication preparation, and medication administration phase. So we have to monitor, evaluate, and improve the quality and safety of these processes. We can do this by applying the quality indicators to these processes. Aim of the quality indicator is to detect how well the current system are working, allow the comparison between entities that promote shared learning, enable assessment of improvement over time, and improve transparency. Some of the importance of quality indicators are QIs enable the efficiency of corrective measures to assess and enable comparison of data between the institutes of similar characteristics and help to set a benchmark. They are also important in the process of accreditation and certifications. They identify the priority areas and develop action plans to drive improvement in quality care and outcomes. Quality indicators can be classified as non-clinical indicator and clinical indicator. They can also be classified based on structure, process, and outcome. For medication management, they can be classified on the stages of medication management. For example, indicators for prescription, indicators for procurement, for storage, dispensing, administration, and monitoring. We can also track the indicator department-wise, such as indicator for pharmacy, indicator for IPD, and indicators for OPD. Today, we are going medication error is total number of medication error divided by total number of opportunities multiplied by 100. Some of the examples of medication errors are prescription errors, transcription error, dispensing errors, administration error, and monitoring error. This particular indicator can be captured through prescription audit and the medication error audit. This can be also captured by self-reporting and reporting of medication errors. Next is percentage of medication error due to wrong patient identification. Any medication error resulted from wrong patient identification shall be counted in this indicator. Formula is number of medication error resulted from wrong patient identification divided by total number of medication error reported multiplied by 100. Third, percentage of medication chart with error prone abbreviation. Every organization shall have a list of authorized and unauthorized abbreviations which can be made by referring the ISMP guidelines. Number of medication chart with error prone abbreviation divided by number of chart reviewed multiplied by 100 is a formula to capture and calculate this indicator. Percentage of inpatient developing adverse drug reaction. Adverse drug reaction is a response to a drug that is noxious and unintended and which occurs at the dose normally used in a man for prophylaxis, diagnosis, or therapy of a disease or for a modification of physiological function. All ADRs should be reported, and formula to capture this indicator is number of patients developing ADRs divided by number of inpatients multiplied by 100. Percentage of adverse drug reaction due to high-risk medicines. Hospital shall have a list of high-risk medicines and all staff shall be aware about it. Any ADRs resulted from these high-risk medicines shall be counted for this particular quality indicator. Formula is number of patients developing ADR from high-risk medicines in a period divided by number of patients given high-risk medicines in that particular period, multiply by 100. Next is percentage of cases who receive appropriate prophylactic antibiotic within the specified time frame. Appropriate prophylactic antibiotic should be in accordance to the hospital policy. The numerator shall include patients who have received the appropriate drug and dose within the appropriate time. Formula used here is number of patients who did receive appropriate prophylactic antibiotics divided by number of patients who underwent surgery in OT multiplied by 100. In this particular indicator, there are certain scenarios like in case of clean surgery, when the patient who is not given a prophylactic antibiotics and since it is not indicator, shall be counted as a compliance and should be counted in the numerator. Whereas in other case, when the patient is given the prophylactic antibiotics and it is not indicated, it shall be counted as a non-compliance. Next is compliance rate to medication prescription in capital. It is mandatory that every prescription shall be written in capital. This particular indicator shall be captured through prescription audit. We can do it based on the sampling techniques. Formula used here is total number of prescription in capital letter divided by total number of prescription reviewed multiply by 100. We have now seen the clinical indicators. Moving towards some of the non-clinical indicators. Basically, these are for the pharmacy department. First is stock out rate of emergency medicine. A stock out is an event that occurs when an item listed as an emergency medicine by the organization is not available upon the requested need date in the organization. Formula used here is number of stock out of emergency drugs divided by number of drugs listed as an emergency drug in hospital formulary multiply by 100. Next non-clinical indicator is percentage of procurement through local purchase within the formulary. Formula is number of drugs purchased by local purchase within the formulary divided by number of drugs and items procured in the hospital formulary list. Percentage of procurement through local purchase outside formulary. For this particular indicator, this includes medicines or consumables which are taken by the patient before admission to the hospital and need to be continued, but it is not included in hospital formulary and hence it is not available in hospital stock. So the formula used here is number of drugs and items purchased by local purchase outside formulary divided by number of drugs and items procured in the hospital within as well as outside formulary multiply by 100. Percentage of drugs and consumables rejected before preparation of GRN, that is good receipt note. Number of drugs and consumables rejected before preparation of GRN divided by total number of drugs and consumables received before GRN multiplied by 100 is the formula to capture this indicator. In this particular indicator, when you are capturing the numerator, ensure that you are taking a total quantity and not the number of orders. For example, if there is an order which has 30 items and out of 30, if you have rejected 10, the calculation should include 10 divided by 30 into 100. Percentage of variation from procurement process. Every pharmacy department should have a clear defined procurement process, and for any variation to this particular process shall be considered as a deviation, and formula used here is total number of variation from the defined procurement process divided by total number of items procured multiply by 100. Moving ahead, these are some of the other indicators which we can edit in our quality indicator list other than the mandatory quality indicators which we discussed right now. This can be decided based on the need and the requirement of the organization or the particular process. For example, if we are constantly finding a non-compliance to the storage of LASA or high-risk medicines, in such cases, we can have a compliance storage of LASA and high-risk medicines as one of the indicator. Other indicators such as time taken for medicine dispensing, time taken for dispensing of emergency drugs, or compliance to narcotic prescription can also be included as the additional indicator. Moving more ahead, we can also have adherence to aseptic technique while administering medication as one of the quality indicator. This can be captured through audits such as checking compliance to hand hygiene, or checking the judicial use of PPE, or checking the compliance to injection safety practices, etc. Some of the clinical indicators can also be set, such as receiving thrombolytic agent for stroke patient within 1 hour, or starting antibiotic within 30 minutes for the sepsis, etc. Now these QIs what we monitor shall be revised periodically and ensured that it is tracked properly. But just monitoring the quality indicator is not enough. We also have to share this data and the results with other stakeholders. This can be either done by using a newsletter or through emails, or discussing these quality indicators at various committee meetings such as drug and therapeutic committee meeting, or hospital infection control committee meeting, or critical care or morbidity or mortality committee meeting, and quality steering committee meeting, of course. Any improvement and good compliance in the indicator shall also be motivated. In this, we can facilitate the department or the team for doing a good work, which will definitely encourage their morale and help them serving a good practices. Setting a benchmark to quality indicator is also very important. This can be either done by analyzing your own data or by referring some international or national guidelines. Quality indicators data verification or validation is also important. This can be done by checking your source data, which can be done at the time of audit or during your daily departmental or monthly departmental rounds. Whenever you're getting a constant good compliance to something, do not ensure or do not understand that everything is going good. In such cases, you can authenticate, you can verify the authenticity of data by having a surprise audit, or by having some awareness drive, or by challenging the knowledge of the person who is capturing that particular indicator, etc. Moving toward the root cause analysis, like every indicator, whenever we are monitoring, in case of there is any deviation in the indicator, we have to do a effective root cause analysis using the 5 why technique. And some of the common root cause analysis what we encountered in the medication management indicators, such as any causes related to people like casual attitude, new staff, untrained staff, work burden, shift change time, physical or mentally unfit staff, or illegible writing. Some of the environment related causes such as poor drug storage, poor lighting, poor ventilation, and humidity. Equipment related causes such as defective equipment, and some of the process related causes such as 10 rights not observed, or wrong labeling, or wrong dispensing, no cross checking, wrong stocking, etc. All these root cause analysis shall be addressed with appropriate corrective and preventive action. Some of the common corrective and preventive action what we take are like training, awareness, counseling, manpower recruitment, stock rectification, policy revision, and providing adequate resources and a space. These are some of the things to remember, like we have to revise our quality indicator periodically. Quality indicator verification and validation has to be done. Discuss the quality indicators and review it in the committee meeting. Have a feedback shared. Felicitate the good practices and the good compliance, and setting the benchmark for our quality indicator. I hope my presentation gave you some clear idea about how to select the quality indicators, how to monitor them, analyze them, and track them for the good improvement. Lastly, I would like to end my presentation by saying the total output of monitoring quality indicator is that patient will be remembered long after the price is forgotten. Thank you. Any questions?